5 years old.
Yes, ma'am, you may start now.
Old girl with developmental delay, crawling at 1 year of age, started walking without support at 2.5 years of age, and the motor milestones keep regressing every time she has seizure with some recovery. Currently, she's walking with support. Speech, she had 4 to 5 words at 2 years of age, words. Now regressed again after seizure onset. Understanding, she has occasional response to name call, recognizes family members. She can follow simple commands when she's seizure free. Better responses when the seizures are controlled for 2 to 3 months. So seizures started at 2 years of age. Initially, she had vomitings followed by seizures. Treated outside, started on medications. Again, after 1 year, one episode, so the frequency was very less initially. Then every 6 months, she started having recurring seizures in clusters. They last for 1 month and then they get controlled with some medication. During this cluster, she has regression of milestones. She loses her walking ability, she has a lot of tremors, and speech goes away, understanding also decreases. So current frequency is around 1 to 2 seizures per month. Semiology is right side or left side deviation actually. This was one episode which they showed me in the video, but from the history papers which they had, initial seizures were left side deviation of eyes and unresponsiveness. Now she has right side deviation of eyes with unresponsiveness. And one episode where she had a few episodes where she had uploading of eyes with perioral twitching and bluish discoloration with unresponsiveness. So only once she had a clonic jerking of both hands. So most of the seizures are focal and different semiologies are there. All seizures are before falling asleep or with each sleep. No history suggestive of any spasms. So this is a seizure. She's not responding. Confused and slowly goes into uploading of eyes and perioral twitching. At the end, there is some right side deviation. So these are the type of seizures she has. Coming to the rest of the history, birth history, it was a full-term emergency cesarean section because of decreased fetal movements and fetal bradycardia. Baby did cry immediately after birth. Birth weight was 1.85 kgs. She was in NICU for 1 week for low birth weight. No seizures, no oxygen requirement. She was just given prophylactic antibiotics for 2 to 3 days and was on feed. So nothing significant happened in that 1 week. Family history, she's first born to third-degree consanguinity married couple. Mother has congenital disc diagnosis, no other neurological complaints in her family. Examination, head circumference is appropriate 49 centimeters, weight and height were appropriate at 10 to 20. Neurocutaneous markers or alopecia or rash. Vision, she was fixing following objects. This is at 5 years, 8 months. Intermittent, but to the call and responses, there was eye contact. Cranial nerves were normal. She turns to sound if she is interested in what we are make. Sound is reaching for objects with left hand. She has some reluctance to use right hand, which happens intermittently again. We had a tremulousness of hands and legs while walking and while reaching for objects. This was 15 days post seizures. There is hypotonia in all 4 legs. There was good anti-gravity movements. DTRs were 2+. Gait, she was walking with one hand support with significant shaking. So, developmental delay with refractory focal seizures, with regression after seizures, with partial recovery, post control, with plus minus autistic features during the periods of bursary, which also tend to improve slightly. So, examination is showing central hypotonia, ataxia, and action tremors. So, with this thought process, developmental epileptic encephalopathy may be mitochondrial because of the recurrent regression which has happened. This is flare sequence showing hyperintensities in periventricular region. And also
what age?
3 years. So Centrum semi-ovale hyperintensities are there. The watershed areas or non-specific white matter changes. Switch off connects. T2 coronal sections, again, those in and around the occipital area, the white matter hyperintensity. Predominantly periventricular. But they're not like PVL. They will be coming like near to the ventricle compared to this, is what I thought. Same areas, hypo here. Hypo. To same area showing hyperintensities. No, brainstem is fine. Basic area. So this is an EEG. There was one EEG done in June 2022.
So back to the MRI. So this one is like PVL mimic. So you have to match PVL mimics with your history, examination, what are the
EEG done before this was only in focal spikes. I could not find the report. In November, this was a different patient, this EEG. So here it was showing like a continuous spike and wave kind of pattern. So at this point of
what is the spike wave index? We had a good EEG.
print. It was not reported, but whatever the pages, all of them were like this. So
this is during sleep, but during wakefulness, or there's virus.
Surely I mean, the break they have not given, but I don't think it was done in the awake because she wouldn't be cognitive. So at this stage, whole exam was sent.
Left more than right.
Left more than right.
Amplitudes.
But in other ages, there was no such pattern. So at this stage, whole exam was sent, and that was showing biotinidase and LAMA2. Both are homozygous. They are missense variants. Biotinidase, this particular mutation was reported in one patient. So they have given it as likely pathogenic. LAMA2 was not reported, so uncertain significance. So post this biotinidase levels were done, which were low, 0.1. So she was started on biotin, and because of the CSW, before the whole exam report came, she was started on steroids because of the EEG pattern. Seizures were controlled, but motor and cognitive malus, there was some improvement over 2 months. By then, the genetic report came and was started on biotin. Initially 5 mg. Later, after 6 months, she had seizures, so it was increased to 10 mg 2 times a day. She continues to have focal seizures like this every 6 months, and every time she has regression. So after 1 year again, EEG was done because of the focal seizures and regression, which was reported as hypsarrhythmia. So this is the kind of spikes which had increased. They were taking regularly biotin because they had been explained about the natural cause. Particular age. So again, she was given steroids for 2 months. After the tapering of the steroids, she immediately started having seizures within 5 days after completing the 2 months course. But the EEG had shown some improvement. This is the EEG post steroids. So here, actually, it's saying that left was not there, slightly on the right. Reality here. Yes, sir. Yeah.
Yes, the second. That's why it is looking a little better. It's actually, I can say, slow and lot of sharp waves in the second post event.
Yes, sir. But I think that high amplitude slow waves.
Yeah, that's sensitivity is different. That's that okay.
Can see an auto maximum at least in 2 slides, 3 slides. on topic. Yeah, correct. We can see that a lot of sites do have an open max. Maybe topic tables. Doesn't matter, but because on the different because something for the night house. Just show a lot of activity on this. Maybe this is not going to be so helpful. Except sometimes you are able to capture and people find out.
These all printed, which any deleted.
Just going back, can I look at this, find this, show, at the time of the other question, we get tests, this, tube cycle, can see how significant the third forms from observation, right? So what I'm not, mechanic acids, so you get particle to particle.
That is but
That would be one. Forming up, which really is this an eclectic nutrition? Because of course, the illness is critical for most forms of vitamin insufficiency. So, pathology, something as vitamin insufficiency. That is something that you might want to think about.
levels.
It's not an uncommon thing to happen. Right? You let it range one direction because you have one output class to yourself. It doesn't, they should have, when things don't fit together completely, then you got to think again. If you're thinking that on then. It's just discussion.
Yes.
I mean, completely wrong.
Also, were there any other phenotypic features of when there's a chest? Like any alopecia, skin changes, or anything. And it was not. But it needs so, and
Even the clinical course, seizures are quite late onset. There was starting was developmental delay predominantly. Then the seizures started, and clinical seizures are always very small, focal, few seizures. Any mild change in antiepileptic they get controlled, but the EEG keeps worsening every 6 months. What?
As I said, we need to look at another case because they might be taking their research quite disease for the people because of the people. Like you need to probably get a regular study for because maybe I will go, my entry point would be also at we will be looking to the potential with the genetic system.
Yeah, the other thing sometimes is that you have to go back and look at some data again. Sometimes it also depends on your platform on which it was done, and sometimes if you set the same thing to another show company, you might get another result. These are common challenges we face. So, is there application or something else in another?
the key for the word for it to be missing. You add to it the orders. So, if biodynamics levels normal, then is there any extra field steam for checking other carbon state efficiencies? What is it?
It depends on the original. I think you see what so it's an modern thing. You know, sort of certain ways to say the access to this technology and then get a result. And then I could follow that. So as an analysis is what I'm helping sort of address the doubts. That's then for this principle which I have another pathology is this is to study the lack of it. I should find the common same experience. So I'm tends to be the balance. Tends to be stability and you can see that MRS very energy study. The proton MRS ratio facility that convention is a marker for possible design of this picture. Also the computer service. I think I found the issues in conversation. But again, I'm going to look at both and I want to look at the funding expense and you understand that they go simply able to target deep and things. All depends on the sequencing, what kind of data so, so
Parents, no.
so you don't bring this are you doing this? Are you doing it as a family study on field? Informative tools, the suspecting that there is a third degree of consent with the system.
I did because they got bad attendance low, they didn't advise for the segregation.
So that's it. My- yeah. If you know that, it's find it out that it's not staying in one either, so the state serves and share and the station. Provided it's
Yeah, it was. So because Lama 2 was there, the CPK was done.
Before you proceed, because I wonder if that's some surprise. And then I don't have local questions. So first, follow the path, you got some answers, but it doesn't. From my perspective, I would look at the clinical presentation, look at the serology, how the looking is, and also baseline deficits, channels. And they're all pointing towards the, at least a left hemisphere naturalization.
Because
I think that, that's what we're-
some decrease due to right hand.
yeah, that's what you pointed out, and that is what was maybe apparent from the description skills, and then also pointing towards language reduction. So my focus with the imaging would be in the diacetyl region on the left side. And even if you don't see anything just like this, I would certainly try to bring it up with the neuroradiologist. Of course, you didn't know it's very specific. Nothing was happening, but beyond the abnormalities that are obvious, one would try to explain the deficits that the child has. And each time there is improvement, it's you frequency, there is some kind of improvement. So there's clearly a role for looking at other treatments for the seizures. Again, this is coming from like an adult perspective, focusing much more on epilepsy than like the general. Because sometimes it's not uncommon to find photocortical dysplasias in the setting.
Was the biotin level checked for this child after treatment?
Yes, it was repeated. It was only the screening part, so 15 units after treatment.
What was the normal level for this lab?
Up to 50. Less than
50.
more than 50. More than 50. Yeah.
Yeah, so we haven't achieved the level. They maybe the child might be getting the breakthrough seizures because of that.
Okay, this is biotinidase levels. Biotin levels are not.
Yeah, biotinidase levels only. Yeah.
They wouldn't increase. They wouldn't increase, no, with biotin treatment. Their enzyme levels.
It should come back to at least reasonably. Levels should increase. Sometimes holocarboxylase deficiency also can cause where you need a higher doses of biotin. So up to I have one child where I have gone up to 160 milligrams per day. So is it worth increasing the dose and seeing?
We've increased to 30, but
It work for increasing the dose.
Dose of biotin and see.
Expect the biotin level, expect enzyme activity response to biotin supplementation. I think it's worthwhile trying a much higher dose of biotin.
Hmm.
I don't like to give you some effectiveness and no worries about that. But I would anticipate a genetic mutation which was previously associated with a very low level.
the point where she presented it after all this was done. And again, same regression was going on. So because it didn't feel like biotin has to improve. I reviewed the literature, whatever it is, they do improve. So just reviewed, and I found this that valproate might cause decreased absorption of biotin, and that might be affecting the treatment. I don't know. So I stopped her valproate. I think like every time she had some improvement with whatever change they made, basically, whether it was steroid or anti-epileptic, she had some improvement. So she had some improvement, but again now she's having seizures, again regression. So this is the current EEG. A lot of which one? Biotin days level. Medicine. So this is the current EEG. And I kept on reviewing and I just couldn't find. I was thinking maybe there is some treatment for biotin which I'm missing, or there are some cases.
I think the natural history of there is a focus on the with some of the development in satisfied the efficiency. Is that being working hypothesis? I would go back and look at the exhibit and carefully back to and also you feel sometimes you get more information when you compare sequences, but I think there may be financial implications for the primary care. Yeah, additional. For instance, might be a person. We find back and confident that has to take something and really have clarity but you also define
Organic acids and other workup. I have asked the genetic people to relook at the exome, but probably one more.
yeah, or sometimes the different lab in between the two platforms. And it's better than this.
Yeah, first I thought reanalysis, then probably add.
Awake record updated for the current seasons.
She won't cooperate for a awake recording.
Because can we comment like CSWS before seeing an awake record?
We have just a very brief 1 or 2 minutes awake record in which the epileptic discharges are coming down. So we can't get a proper awake record. It's possible. Yes, it's possible. It's at me.
In fact, on the same line, my whole definition of how when the child is also qualified. At some point in time of very prolonged monitoring with people recordings to be done like at least one single day because like there will be seizures need to be captured. One but separate. So that they can be they're all stereotyped. They're all coming from the same region. Because now the child is definitely older. So you're bound to find something like some vocabulary. And even if you do not clinical semiology of that one seizure clearly is not what you said. So at this point in time, at least you want to characterize the seizures because they are doing the damage. As soon as the seizure drops down, the child does do better. So while you're working on the rest of it, that's only investigation as far as clinical evaluation is concerned. Prolonged ictal EEG monitoring, video EEG monitoring probably is essential, not one, maybe more. That's what I think. And that usually provides a lot of information about where to focus on interpretation, because usually epilepsy is one area where radiologists need EEG localization to better show you.
There was a recent head injury for her outside they had treated. So they did a CT because she fell down from a bike. So there is ventriculomegaly compared to the MRI. There is increase in the ventricular size. Occipital posterior region.
Yeah, exactly. Yeah, look at it. Yeah.
So always compare so don't compare CG with art. And so art should also
Another this was accidentally done and it's like just a review that seizures always improve. Rest of them development might not improve, but seizures always improve. And in this case, that was not happened. So,
that's why your whole hypothesis really looked at.
leave it.
Those are very
Probably repeating an MRI also will give more.
I think you should certainly options. You certainly should think about like DNA pieces of growth. And actually, so really basically go back to the building blocks and start.
Forget this report and start fresh.
I think it illustrates that we are all, what is that famous saying that the eyes only see what the
Yeah.
right? So something along those lines. So we tend to get easily led away because we have one anonymous. So solution lesson for all of us. Really.
That was it. I call the next presenter, Dr. Charishma. She's a consultant neurologist. Name's Vasant.
So while this cleaning up, we have a child on the board actually. This child was developing that main and development B deficiency. Another child in the water. And he was managed for that. And then last 2 months he started having epilepsy passions. And then they tried into anything in mass spectroscopy also. And that is several observations. Biometric seizures and which slowing on the steps. So when the data was the same, it's a technical from that's development. But we had the year that elder SIM as a 10-year standard previous, and she had PTPLAG, which is associated with mitochondrial myopathy and myopathy. As the lab just look at that sequence, then that is some EPC, there's development deficiencies we not. So we can 48 hours, you can write to the information that is also. So I just want to say that when things are clinically not matched, or they might be some new things are you can feel last they can work this back. We had a real working line system. It's like she has yes, focus. So that was quite big. So that was a nice thing. Like that. Just because she had the heads. I think it's. Yeah, this was government responsibility. That does not have government obligations. That does not necessarily. But she was not the bad son of the
Very good evening to everybody present here. I'm Dr. Charishma. I've completed my MD Pediatrics. I've joined as a non-academic SR in Women's Department of Neurology. I'm here to present a case. My moderator is Dr. Siddhesh. There was a 17-month-old male child who was brought with complaints of not attaining milestones since birth, and he was having abnormal movements since 6 months of age. And a seizure episode, there was only one episode which he had at 6.5 months of age. Coming to history of present illness, the birth history was absolutely normal. The parents noticed the child was not having they noticed that the child was not achieving the milestone when comparison with the peers. He was not able to hold the neck and he was unable to sit with support. Coming to the because the problem is since in the developmental milestones, I want to start from the developmental milestones itself, the history of presenting illness. The child did not. The child did not attain any neck holding, neither rollover nor sitting with support in the gross domain. In the fine motor, there was no unidextrous reach or the bidextrous reach, and there's no immature pincer grasp. Coming to the language, there was only cooing present, which the child started only at 5 months of age. And there was no monosyllable or bisyllable or one-to words with or without meaning. Coming to the social adaptive, this is slightly in a better domain. He achieved the social smile at 3 months of age. He was started recognizing the mothers at 4 months of age. He started smiling at the He started smiling at the mirror image at 9 months. That also was delayed, and he's not yet attained the milestone of waving bye-bye.
Coming to the continuation of the history, the second main complaint was abnormal movements in the hands in the form of writhing or twisting movements were noted more in the left hand when compared to the right hand. There was no posturing, neither jerky component was present in the movement, no rhythmic oscillation of the movement was observed. They were present only during the awake state, they were intermittent in nature. But the child is conscious during the episode and there's no cry or painful movement of the hands. At the age of 6.5 months, the child had one episode of fever followed by one episode of seizures on the second day of the febrile episode, which was lasting only for 3 to 4 minutes. But the semiology was, it was not having any tonic-clonic movements, neither any urinary incontinence, but he had only a staring look, which lasted only for 3 to 4 minutes. The fever subsided and no further seizure episodes were noted, and the child was again in a stable condition. Coming to the negative history, there was no history of any abnormal cry or irritability, no history suggestive of any cranial nerve symptomatology, no other abnormal movements elsewhere observed in the body, no history of any altered sensorium, no history of any behavioral arrest, no history of any episodic worsening of the symptoms, or there were neither any swallowing difficulties. There was poor weight gain despite adequate feeding in the child, but there was no history of any feeble cry or high-pitched cry, neither fever or recurrent respiratory symptoms, and no history of vomiting or abdominal distension was noted. Coming to the antenatal history, this was a spontaneous conception at 26 years of maternal age. The number of living children were 2. There was only one abortion at the termination of pregnancy, which was a personal reason. There was a history of query. There was a doubtful scan abnormality in the first trimester. No documents available, but told on history. But on subsequent scans, the parents were told it's to be normal. There's no history of any diabetes or hypothyroid, any fever with rash or tetrogen exposure in the mother. There's no history of increased or decreased fetal movements observed in the first trimester. Coming to the natal history, it was a term baby which cried immediately after birth with a birth weight of 2.5 kgs. There was no NICU admissions immediately after birth, but on day 3 of life, in view of NNJ, he was admitted for phototherapy and was discharged again in a stable condition in 2 days. Started breastfeeding on the first day of life. Immunization history, he was immunized as per schedule according to the national immunization schedule. Coming to family history, he was second in birth order, born out of third-degree consanguineous marriage, but there's no history of similar complaints of delay in developmental milestones in the family or the elder sibling noted. Coming to the summary based on the history, it was a 17-month-old male child born out of third-degree consanguineous marriage with complaints of delayed achievement of milestones in all domains, one episode of febrile seizure, and involuntary writhing movements of both hands with no other focal neurological deficit or raised ICP features. So, more in the form of choreiform movements. They were present intermittently. There were no jerky movements as such. It was flowing from mostly proximal to distal. The flow was there. Yes. More component was not the twisting. Only the fingers were. I have a video, sir. In that also very mild is noted, but there's a video present. Can I proceed? Coming to general physical examination, the child is conscious, alert, and active, lying on the bed in the hypotonic posture. The hands and legs in extended posture. The bilateral upper limbs, proximal-distal flowing movements are observed. No paler ictocyanosis. The vitals are all normal. Yes. One is because it's born out of the third-degree consanguineous marriage and a global developmental delay. It's all domains, more than 2 domains. First, thinking of any metabolic IEMs to be ruled out. So, science and yes. Any glutaric. Any organic ischemias. Glutaric aciduria. mitochondrial metropolis. But seizure, only one episode of seizure, that too at 6. Coming to the anthropometry, there's no microcephaly noted. The weight is between the 3rd and 15th centile. The length is less than the 3rd centile, and the mid-upper arm circumference is less than the 3rd centile. Basically, it's going to failure to thrive, not adequate weight gain. Coming to the head-to-toe examination, the head is normal in size and the anterior and posterior fontanelle are closed. No abnormal movements are noted in the head. Face, there's no dysmorphism, only for the frontal bossing is present. Eyes, no ptosis or no cataracts. Fundus is normal. Neck, ears are normal. Oral cavity, there's no cleft palate or the dentition is appropriate to the age. No chest deformities. The extremities, no evidence of any polydactyly or syndactyly. The genitalia are normal. No contractures are seen. And skin is normal and no neurocutaneous markers are seen. Coming to CNS examination, the child is conscious and active. All the cranial nerve examinations are normal within normal limits. Coming to the motor system, the upper limbs, the bulk is normal, and the lower limbs, only thinning of the muscles is seen bilaterally. Coming to the tone, it's hypotonic child. There's a resistance to passive movements is decreased in both the limbs, and range of movements are increased. Impression is a central hypotonia with a head lag is present. Coming to the power in both upper and lower limbs is greater than 3/5. Neck, he's unable to lift the head above the ground. Abdomen is partially moving the bed with support. 17 months. He's just moving again. Okay, sir.
Expensive because it's not a complete.
Coming to the reflexes, there are bilateral extensor reflex. Plantar is bilateral extensor. Deep tendon reflexes, the upper limbs are present bilaterally. Lower limbs 2+ in both the lower limbs. Coordination of movements and stance and gaits in this child could not be elicited. Involuntary movements in the form of writhing movements in the upper limb noted. These movements were absent during sleep. Sensory system, normal. Coming to the examination of cerebellum, generalized hypertonic and head lag is present. There's no titubations in the head, no fluttering. Lower limbs, he's unable to, he was not able to walk, so we couldn't examine the lower limb thing. Trunk, central hypertonia. Other systems are normal. There are no spinal deformities also noted. We're trying to elicit the head lag. We try to do the ventral suspicion to differentiate between the central and peripheral hypertonia. It's evident of central hypertonia because there was a head, was able to partially hold the head. This video is to show the abnormal movements of the hands. Very minimal movements are seen. This movement he was constantly doing, we couldn't record it very properly. Based on the history and examination findings, the provisional diagnosis of what we thought was a clinical syndrome which is fitting into a central hypotonia with global developmental delay, with a failure to thrive, with febrile seizures, with chorioathetosis. Coming next to the localization, it's a global cerebral dysfunction with more involvement of the white matter because more of the motor domain was affected rather than the cognitive thing than the gray matter, with the basal ganglia involvement because of the involuntary movements we were considering in the basal ganglia. Etiological diagnosis, the first thing we thought was neurometabolic disorders. Specific vitamins. Mitochondrial. Developmental encephalopathy was epileptic encephalopathy was one we thought. Developmental encephalopathy, not only one seizure was the against feature for that. Global developmental delay with intellectual disability with an epileptic thing. So that's it. Isolated but to term it as encephalopathy, we need to the last we thought was bilirubin-induced neurodevelopmental disorder, but very less likely. Coming to the investigations which we did in this trial, the EG done was normal. The thyroid profile also was within normal limits. The CPK level was within normal limits. MRI brain was normal. The films are not available because they had lost the films. We couldn't put the films. Tandem mass spectroscopy was normal. Urine GCMS showed non-specific mild to moderate elevation of 2-hydroxyisobutyric acid, acetoacetic acid, and thiodicglycol acid, which was not correlating with any of the above mentioned symptomatology. Bera and eye evaluation done in this child was normal. USG abdomen was normal. 2D also was normal. We sent for a mitochondrial genome sequencing, which came out to be negative. In the whole exome sequencing, we got a GNAO1 mutation in exon 6, autosomal dominant heterozygous variant. Neurodevelopmental disorder with involuntary movements was a phenotype. Third degree consanguineous.
Was that?
Depends on, the autosomal dominant penetration. Yeah.
But it's heterozygous.
What is the parental?
We have not done it, ma'am. We are planning to get it done.
Yeah, unless we do it, we cannot say no.
We can't. Yes.
Any trial
Clinic.
of DOPA or DOPA
We've
rest?
started a trial of levodopa, ma'am. They are on follow-up. They're telling there's a very mild improvement because we started with a minimal dose. We're in the process of increasing the dose.
Okay.
Missense. Three. There was one same glycine and tyrosine. Arginine reported thing. 11's same variant, only one. 11.
CSF neurotransmitters, amino acids.
Not done.
Okay.
A very brief information about the GNA1 mutation. It's a Gnavan-related neurodevelopmental disorder, generally presents with hypotonia in 91% of the individuals, movement disorders in around 89%, epilepsy in 53%, and then with developmental delay. This disorder encompasses a broad phenotypic continuum that includes hyperkinetic movement disorders and or epilepsy and is typically associated with developmental delay and intellectual disability. Viewed by the age of onset, three clusters can be observed: infantile onset developmental and epileptic encephalopathy with or without prominent movement disorder, infantile or early childhood onset prominent movement disorder and neurodevelopmental disorder with or without childhood onset epilepsy with varying seizure types, later childhood or adult onset movement disorder with variable developmental delay and intellectual disability. This is a abstract. Clinical course of 6 children were diagnosed causing a severe distinct movement disorder. In this, more of the hyperkinetic movements were disorder. Most in the presenting patient, the choreoathioid movements were very we couldn't elicit it much. So same thing they have mentioned in the results. All 6 patients exhibited global developmental delay and hypotonia from infancy. Chorea developed by age 4 years in all, but one patient who developed chorea at 14 years. So this indicates maybe we can expect the chorea to worsen in this child. He's only 17 months now. Maybe it would be a progressive movement disorder in the long run, in the near future. For responsive and deep brain stimulation are the modalities we can try for them. For the chorea component. Development therapies should be. Yes. Thank you.
The next presentation will be by Dr. Asuri Narayan Prasad, sir. Just a few minutes of 5 to 10 minutes will start.
And then screen sharing is, let's just close the participants.
Your screen share option is not being given to you.
Okay.
You have to tell them.
No, sorry, bottom it is this. Yes, no, bottom share. Yeah. Okay. Bingo. Just as a verification. Nothing, there we go. So, well, thank you for that introduction, Ramesh. I tend, when we were discussing this talk in the evening, I thought we'll all be tired after a long day of so much of talking. So thought we should have something very informal that would, that might be of some, what do you call, that provides some insight for the youngsters in the room primarily and some entertainment for the older individuals here. So my wife will probably have something to say at the end of this talk. One of my favorite pastimes or hobbies or passions in life is traveling. And I have now spent almost 4 decades as a physician, and it's been a journey. So I thought that we'd take a moment to walk you through my professional life, and maybe there are some lessons for people to learn from this and also be entertained. So, life's journey takes you through many trials and tribulations. And when you're young, you're full of hope and optimism, and you want to get somewhere. And you never take the time to look back and what are the steps that you have already gone through, how many steps along the ladder of life have you already climbed. So, I'll just start with a little bit of let's hope that this video works. So this is a little video from a childhood film that I saw. It was called Chitty Chitty Bang Bang. I don't know how many of you have children of your own, but it's a very entertaining film. If you ever get a chance to see it, do see it. But coming to more serious things. So I just gave this talk as a reflective talk many years back. And I'm just trying to say a few things about what I witnessed, the enormous transformative changes that have happened in medical science over the last 4 decades, and have really brought changes to the lives of the children that we treat. And these 3 slides at the top are this, one is a book written by John Bunyan, which was published in 1678. It is about the Pilgrim's Progress. It's another tale of a journey. And then we have in our own Itihasas and Puranas, we have in the Bhagavad Purana, we have descriptions, geographical descriptions of the terrain through which many of the events that the Itihasas have. And then there is also another description, a travelogue by one of the saints, Vadiraj Swami, who has written this Tirtha Prabandha, which is more of a Dvaitin concept. But anyway, the important point is that our ancients also wrote travelogues. and talked about the journey and the importance of different things that happen to you when you visit kshetras. So this Pilgrim's Progress is this sort of journey through different points. I'm having a little bit of technical difficulty here. Yeah. So I just wanted to familiarize the audience with a personal account of my journey in the field of pediatrics and neurology and illustrate examples through how advances in science have influenced clinical medicine and particularly child neurology, and share with you a few case studies through my lifetime, which illustrate these points and the personal significance of the title that I chose. So my professional life began with medical school in Delhi, Maulana Azad Medical College. I don't know if people recognize this picture. It's the main entrance to the hospital. The medical school. This is the auditorium, and this is the main building where a lot of our initial classes were held. A lot of memories of living in hostel. This is the medical school hostel. And I used to live in a room somewhere along this side. And our favorite haunt used to be the coffee house, the Indian coffee house, which I don't know exists anymore these days. But they did have liveried waiters who used to bring coffee and hamburger, which was a popular sort of snack that people would have. Anyway, so when I started medicine at the University of Delhi, neurology was considered to be an armchair discipline. Basically, there was a term that I borrow from the textbook of surgery, Hamilton Bailey's textbook of surgery, which was called masterly inactivity. So you basically sat in a chair and postulated or thought about where the localization was, and then let life take its course. That was neurology to a greater or lesser extent. I don't mean to demean what was done, but a lot of what we do know in neurology today was really can be actually attributed to the very fine bedside observations that these old style neurologists did. I refer to the classic work of Miller Fisher, who I did happen to, at least witness him at the Mass General Hospital. And Miller Fisher apparently had a whole garage full of notes that he wrote. You'd stroke patients, you would sit at the bedside and you'd make clinical observations and you'd take notes, detailed notes, handwritten, all of them. We didn't have computers in the old days, but those descriptions of by Miller Fisher, clinical descriptions are classics in neurology. There's a particular paper I recall, which is called it talks about the clinical manifestations of ischemia in the posterior cerebral artery region. And the case descriptions are really worth reading for historical interest, for sure. Anyway, so going on, during my days in PGI, while I was doing MD in pediatrics, again, we used to rely upon our adult neurology, DM neurology people to come down and advise us about what to do with our children with pediatric neurology. And of course, the large majority of children had encephalopathy, acute encephalopathy from different illnesses. And of course, tubercular meningitis was the leading cause of many of the problems that these children came with. And so I know that we remember doing a lot of even pyogenic meningitis common. So we used to do a lot of subdural taps. And I just heard Ramesh talk about doing air ventriculograms in his patients even today. So it's interesting to note that despite all these years, some things are still relevant. And our treatment options were rather limited. We had steroids, we had phenobarbital, dilantin, ethosuxamides. The suxamides were still there. And then again, more prayer and masterly activity. So epilepsy surgery was practically unheard of in very young infants or children. And this is going back quite some time. So tell me if you are getting bored anywhere, just let me know. I'll stop there. At that time, genetics and neurology were distant cousins on an interdisciplinary astral plane. Pathology and autopsy were the first degree relatives, which informed us much more. How come I'm not able to move? Next. Seems to be frozen. Hmm? Yeah, thank you. Oops. Ah, yes, we've made progress.
Connection ಇದೆ.
Yeah. Ah, sorry.
It's very
Delicate. Are we on? Yes, I think so. Yeah. Great. So today, I mean, when we look back on what we have today, we have imaging, which is a huge boon. And today afternoon, our discussion. Oh boy. Screen sharing is paused. It was working.
Online is putting. Screen is.
Oh. Technology. It's great when it works. Okay. I can't see anything on my screen now. So anyway, in 2024, we have gone on to move on to better ways of imaging, better ways of getting processing EEG signals, and magnetoencephalography. And genetics and neurology have become inseparable as gene tests provide many more answers than we did before. I hope this works. Yes. So, so this is really where we find ourselves over the last 4 or 5 decades, where there are applications in imaging technology that have helped us make diagnoses. We have new diagnoses, sometimes old therapies that work, and the promise of curing refractory epilepsy. And then there is this whole holy grail, as people call it, the final frontier in Star Trek terms. So I'll just make a few themes. And this young lady presented with status epilepticus. She was treated as is the case in Canada, that anyone who sees this gets snowed with medications and they stop breathing, and then they are put into a tube is put in, and then they are transferred. So no time to take a history. Patients should not be having seizures. That's the main thing. So time is brain, they say, so that's what they do. And she was a school-going teenager who was quite average. And then she was ventilator dependent for much longer. Her seizures had stopped, but when she was woken up, she was agitated and confused, and she had signs of, what was an encephalopathic picture. And then she began to show a progressive accumulation of lactate in her blood. This seemed to be different from the secondary causes of lactic acidosis that we deal with. And as you can see here, even though clinically she had responded, all other parameters of perfusion had improved, she still had lactate accumulation. And she had some abnormal signals in multifocal nature on her MRI. It was really after So we thought that this might partially explain her encephalopathy. But it still did not give us a clue to the possible diagnosis. And let's see if this works. Oh, I can't get the video to. It's not showing on my. Can I stop the share for a second? Oh, here it is. So when I went back to examine the patient.
Mount Washington, Ontario.
Okay, what's the name of your school?
Sacred Heart
By the time that,
High School.
which grade are you in?
In grade 10.
Okay. Have you had any problems with your eyes at all? All your life?
It might be a little bit droopy.
Mhm. Can you take your glasses off for a minute? Okay, look at the camera. Okay. And look up at the ceiling. Okay, look down at the floor. Look at the camera again. Interestingly, when we went back, when we went back over her history, she told us that when she walked back from school, she had to stop and take a breather before she could resume activity. That was helpful as well. So the combination with this, although the MRS that I was saying was not very as good as one would think or one would be able to get it technically these days, it showed an inverted lactate doublet. So you can imagine that at a time when we did not have any imaging, but an appropriate use of imaging would give us a clue to the diagnosis. And this young lady obviously was diagnosed with MELAS. And MELAS was first described in 1984, the year that I just finished my MD in pediatrics and had gone on to work in the United Kingdom. And just if we look at some of the changes, DMD, the gene for DMD was described in 1986. 1987, the antidepressant Prozac was introduced. 1989, the first gene for cystic fibrosis was cloned. And I was working as a pediatrician in Buren, Newfoundland. Anyway, so this young lady had ragged rib fibers on her muscle biopsy. This is related to a subsarcolemmal accumulation of hyper proliferative mitochondria, which stain red on the meson-trichome stain. These days, we don't do as many muscle biopsies, and so this rather ancient methodology has really lost clinical relevance. But at the time when I was at least in the 90s, muscle biopsies were done very frequently. Okay. So she had a mitochondrial DNA point mutation, which was an unusual one, 3291 T to C transition. So she had complex 1+3 deficiency in terms of her respiratory chain complex activity, which we were able to assay. And this is an unusual mutation as the tRNA in this situation fails to undergo a post-translational wobble modification. And we wrote this paper up and was published in one of the journals. I can't remember which one, but it certainly was a less commonly observed mitochondrial MELAS mutation. And she did very well with arginine supplementation, and she's. So we won't belabor all this, but L-arginine supplementation was very helpful in her case. And it kept her out of hospital. At least she didn't have those classic sort of exacerbations, and her seizures remained well controlled. And she was transitioned over to adult care. So I'll just pass that on. We have a nice paper there on MELAS, which people, there's trainees if they want to look it up. I just go back on my reflection on some years when I was in the UK. So when I came to Newfoundland, I worked at this hospital called the Charles E. Janeway Hospital. And Charles Janeway was physician in chief of Boston Children's Hospital. Later, when I got the chance to work in Boston, but I was working at the floating hospital for children, Tufts University Medical Center, where I trained in neurology and pediatric neurology. And so my life also changed after I became a pediatric neurologist at that stage. And I've been in this field for about 3.5 decades. So here is another insight into how advances in genetics changed the picture for us in many ways. So this is an 18-month-old child who did not sit independently until 17 months, had no vocabulary or recognition, had hypotonia with preserved reflexes, suggesting a central form of hypotonia. And the family history was not really that contributory. There was a sibling with speech delay. Parents were non-consanguineous. And the reason why the child was brought to my attention was that the first thing they do is an imaging study. It showed that there was some non-specific atrophy of the cerebral and cerebellar atrophy. And the interesting point was that, again, I like to emphasize this to the youngsters, trainees particularly, as first principles are really critical. You really need to take a good history and do a good physical examination. Don't hesitate to examine, undress the patient, examine the child properly. You'll get many clues to diagnosis. One of the things that we observed was that the head circumference had begun to taper off or fall off the percentiles. There was some other symptoms of blanking out spells and breath holding spells. And this might give you a clue. Oops. No, media was not found. Anyway, you can see that the child is twirling her hands. And that was a clinical clue. And then she was having this hyperventilation. And 1982, this is a critical paper by Hegberg, which brought attention to this condition that had initially been described in 1968 by Andreas Rett, an Austrian pediatrician. And but for a long time, this condition was missed or underdiagnosed until this paper came out in 82. We can see that the clinical description and the clinical criteria were the basis for diagnosis for well over another decade. And in this case, we did sequencing of the MECP2 gene by the time we had seen this patient. And Ruti Amir and Huda Zogby's paper was the seminal work that led to the identification of this mutation. And this was in the 90s, 1999. And you can see that the whole picture of Rett syndrome changed after that. The diagnosis became a lot easier, but not only that happened, we also discovered that many patients who had a phenotype that was similar to Rett syndrome did not have the mutation in the MECP2 gene, but had a mutation in CDKL5 or FOXGP1. Other genes were involved that could produce a similar phenotype. And so that's a picture of Huda Zogby, and basically, I think it's a transcriptional repressor, and it has very widespread effects in early life. And what happens is that at a critical point in brain development, this repressor serves to shut down a number of genes, which results in synaptic pruning and loss of synaptic connections in the brain, and also plays a major role in the cerebral atrophy that takes place in Rett syndrome. Having understanding of all of this has gone on to the identification of a a targeted treatment, which in clinical trials at least has shown a modest benefit in terms of both behavior, communication, cognitive functioning, and this medication was cleared by the what is it called, FDA. And trofinetide has been introduced as a possible treatment. It does produce a few points change in the questionnaires and that are used to assess improvements. Okay, here is another example of what changed. So this is a young lady who we used to see in the Rett syndrome clinic. She had a diagnosis of Rett syndrome, but she had a number of she started having these seizures almost on a continuous basis. So whereas previously she had a better level of functioning, she had become confined to the wheelchair and was almost having continuous generalized spike and wave discharges with what appeared to be almost like a confusional fugue-like state. And for the longest time, we tried different anti-seizure medications and she wouldn't respond to it. So finally, out of desperation, I got her started on the ketogenic diet. And the diet, you see, had fallen out of vogue for a long time. And it was when I was doing my fellowship that I wrote a paper on alternative therapies. And sort of there was a time when the ketogenic diet was being resurrected in the early 90s. One of the John Freeman, who was a professor of neurology at Hopkins, he had kind of taken up some interest in revival. Hopkins became a leader in this field of the ketogenic diet. And what happened out of all that was that when I wrote the paper, it's one of my better cited papers. I got a grant to start the ketogenic diet program in our hospital, Children's Hospital in London. And she was treated with the diet treatment and she completely stopped having all seizures. From wheelchair bound, she became active. She was more communicative with her parents. And her mother used to think that I was like second to, God's descent on this planet. And she always used to come and praise me to the sky. But anyway, this child was helped by the ketogenic diet. So you see, sometimes there's much to learn from history. And the ketogenic diet has gone on to sort of have a revival in the management of refractory epilepsy, not only in children, but also in adults. And there are programs now supporting the diet as an option for refractory epilepsy in adults. So the impact of biochemical genetics is another field where we've seen tremendous progress. And this whole story starts with an 8-month-old child who had developmental impairment from birth, never made eye contact, was very irritable, and she stopped laughing after a chickenpox infection. She became inconsolable, had myoclonic seizures. When she was examined, she had very poor eye contact. Her head circumference was along the 10th percentile. She had a weak sign cry, marked head lag and truncal hypotonia, but increased tone in arms and legs, and brisk reflexes with ankylosing. And this is the picture of the child, unfortunate child. She had white matter leukodystrophy, Krabbe's disease. So the first proband child died because of this. And then the second, she also had significant optic atrophy along with the white matter changes. These symmetrical white matter changes are very characteristic of the MRI picture associated with Krabbe's disease. I wrote a paper on the use of the skin biopsy, particularly using electron microscopy as a tool for identifying inclusions, on ultrastructural examination of the skin. You have access to a number of cell types, and many lysosomal disorders can be diagnosed based on the nature of the intracellular inclusions that are accumulating. We don't use this these days that much, but again, it was a common tool, particularly used for diagnosis of mucolipidosis, one type of Batten's disease, where the ultrastructural examination identified lamellar inclusions, they were called GRODs, and granular osmophilic deposits. And pathology was a very important thing to help you diagnose. And this again was a very interesting experience for me to sort of curate all of that information that was available. And these are some of the architectural inclusions, fingerprint type of inclusions that are seen in the pathology of Batten's disease. Anyway, so this child had Krabbe's disease, and what we did was that the first child died at 2 years of age, but the second pregnancy in this family showed that the prenatal diagnosis showed that the baby seemed to be doing okay. The third pregnancy was affected on prenatal diagnosis, and we were able to get her a cord cell transplant within a few weeks of birth. And she was only about 6 weeks old when she had the cord cell transplant. And this child has gone on to have gone to go to school. She does have some white matter signal change, but a significant amount of galactocerebrosidase activity is detected in the blood. And she has a little bit of tightening of her ankles, but you cannot imagine the difference that an early diagnosis could make in this case. So it's shows you how things have changed. Now, I mean, there are newborn screening programs that have been put in place for Krabbe's. We have more recently transplanted an adult, 2 adults, in fact, with stem cell transplantation, in whom we've been able to see that the disease has been arrested. They were late presentations of Krabbe. And then, of course, we've seen, and you people are now aware of how epilepsy surgery has made a difference in the lives of many children with refractory epilepsy, particularly infantile spasms. And this was a little boy who came to my clinic, and he was having some very unusual asymmetrical spasms, which were very repetitive. And I think you can see those seizures here. Oops. Hope it works. That's not done. So this will go on. Let's skip this video. But he was a preemie, and he had a stage 4 intraventricular hemorrhage. And when we looked at his EEG, he had really a focal hypsarrhythmia. And look at, we did have a brief, this is, I think, one of the more generalized paroxysmal discharges associated with which spread from, became a bihemispheric discharge associated with the spasm. And his ultrasound had shown the hemorrhage evolving into a porencephalic cyst, and he had a very large porencephalic cyst. and he had a hemispherotomy, and his seizure stopped completely. So again, this was, and he began to show signs of developmental progress. Because it was done fairly early, I think there is a role now we could very well recognize for early surgery in children with infantile spasms if you can identify a pathology. And so there is this urgency. And, I have a video of him. Oops. Something has happened. I'm sorry. Final frontier is really the prevention of neurological disabilities through expanded newborn screening. And that's been an amazing story to talk about, and particularly in Ontario, where newborn screening was introduced about, it's now 10 years back, 2011, or even 10 or 12 years back. And we screened for about 28 disorders. And we are trying to obviously add more ones as biochemical markers become available. And this was an interesting experience of a Sri Lankan boy who was born by cesarean section, and which is following an uncomplicated pregnancy. And there was no family history that was that significant. We had an abnormal screen for PKU, and phenylalanine levels were high, but it didn't respond to dietary restriction. Again, I'm having a bit of a problem with the video. I don't know what else I can do to make this. If I click here, there we go. Hopefully it will work. Never got any. Keep trying to see if we can give you a copy of the clip. Okay. That's wonderful. This is a few months later, a few weeks later.
Well then,
Okay.
what's that?
I'm just taking him. Anyway, so the point is that this is a bit old video. Is all of these findings and the biochemical abnormality in hysterins, particularly urine biopterin to neopterin, which was we have two patients. The biopterin was low and the neopterin was elevated, and there was a high neopterin to biopterin ratio, which pointed us to the diagnosis of PTPS deficiency. And in those days, we did not have access to genetic testing as yet, but eventually we were able to do his CSF neurotransmitters and also confirm that he had a low tetrahydrobiopterin level, confirming that he had 6-PTPS deficiency. And this is really a disorder of regeneration of tetrahydrobiopterin, PH4, and then replacement And then, of course, we went on to do a targeted gene sequencing, which identified a homozygous mutation. And this was previously known and was associated with a severe cerebral type PTS deficiency. I will just skip all of that. And when we replaced with BH4 and L-DOPA and 5-hydroxytryptophan, this child had a completely normal development and has gone on to school. He is now almost 17 years of age. He's having some challenges at school in terms of his behavior, but motorically he is completely neurologically normal. He sometimes does a part-time job as a video jockey, and he drives his parents crazy, but he doesn't have major neurological deficits. So again, he comes to our clinic on a regular basis and is followed up. And it tells you how early diagnosis can be transformative in many of these lives. So last 3.5 decades, life has taught me many lessons, successes, failures, struggles. But learning has been a continuum. We are witnessing many medical miracles, and imaging of the nervous system has particularly been a major advance, and advances in genetics and molecular biology and biochemistry have provided us with many, many answers. And in fact, one of the excellent piece of work that I'd probably highlight is the TIDE program that comes out of BC Children's Hospital, treating intellectual disability, early. This TID program. You can access the program. It tells you a very clear algorithm for workup of patients with intellectual disability with and without seizures. And there are a number of conditions that are potentially treatable, and through replacement therapy or modification of their diet. And all of that can help prevent a significant neurological burden of intellectual disability. And so I used to say that when I first did this talk for the youngsters and trainees, I would say that the future is bright. So many people should take up pediatric neurology as a profession. And it's good to see that people are interested, and the number of pediatric neurologists in the country has gone up tremendously. And then the last part is little work. So I made a video. Oops, no. With music. That was life story. And I just leave you with this thought that I did not think to show to all the world my pen and ink in such a mode. Only thought to make I knew not what, nor did I undertake thereby to please my neighbor, no, not I. I did it mine own self to gratify. So when you do whatever you do it for your own self gratification. Swanta Sukhaya, then it gives you some purpose in life. So I leave you with this, what do you call, picture that I drew on a trip to Alapi in Kerala. And say to youngsters particularly, this is, you're in an amazing field at a time when so many things have changed. New therapies are on the block, and exciting times for science and for medicine and for pediatric neurology. Thank you very much for your attention. I hope you are decently entertained.
Photograph together and then we can.
Absolutely. Absolutely. Is this,
We have to stop the sharing. Can I
okay,
say-
yeah, sure, please go ahead.
So shall I stop the sharing?
Thank you, sir, for that wonderful.
One minute. Yes.
Okay. Thank you so much, sir, for showing the journey. So we'll conclude the online session now, and we'll take a picture and join for you.
Thank you.
Hello. Am I audible? Hello. Hello. Am I audible?